Hi, I'm Peter Boland, and welcome back to More Health, Less Healthcare, and our continuing series on maternal health. If you zoom out, look at maternal health in the US, one thing becomes pretty clear. Outcomes don't just happen. They follow the system we build, and that system is shaped by policy. On earlier conversations around maternal health, we often start with morality or economics. We talk about how preventable deaths are unacceptable or how costly poor outcomes are for families and society. But today, I want to focus on something more concrete. I want to talk about the rules because policy is where values actually turn into action. And right now, too much of US policy treats pregnancy like a short-term event, a 40-week episode, maybe a few weeks after birth, and then, well, you're on your own. But that's not how maternal health actually works. Maternal health is a continuum that starts before pregnancy with underlying health conditions, access to care, and social stability. It continues through pregnancy, obviously, and it extends well into the postpartum period, at least a full year after birth. So when policy ignores that continuum, the results are predictable, not unfortunate, not random, but predictable. We end up with gaps in care. We expect people to navigate complicated systems on their own. We assume coverage equals access, even when transportation, childcare, or workforce shortages make that access nearly impossible. And then when outcomes are poor, we call it tragic, as if it were built into the system from the start. Maternal deaths don't just happen. They follow the path policy lays out. What we choose to pay for, what we overlook, and who we expect to fill the gaps. So what would better policy look like? It starts with a simple idea. Maternal health is shaped by three things working together: clinical care, social conditions, and the friction built into the system itself. And it's true that policy has to address all three. And this means really extending postpartum coverage, not just on paper, but in a way that actually connects people to care. It means supporting community-based models like doulas, midwives, and home visiting programs. It means improving how we collect and use data. It also means aligning financial incentives with prevention, not just emergency intervention. Because right now, the system often rewards the wrong things. If your payment model pays more for procedures but doesn't reward fewer complications, then a decision has already been made about what matters and who matters. And that brings us to the numbers, because the policy case here is not just philosophical, it's incredibly practical. Each year, adverse pregnancy outcomes in the US cost an estimated $165 billion when you factor in healthcare spending, lost productivity, and long-term impacts. That's not a small inefficiency, that's massive structural cost. And if we prevented even half of those outcomes, the savings could approach $80 billion annually. And that's just not a healthcare issue, it's an economic opportunity hiding in plain sight. And when you zoom in further, the math becomes even more tangible. Preventing a simple preterm or low birth weight birth can save around $15,000 on average. In some states, that number climbs to about $20,000 per case. So every time a high-risk birth is avoided, there's a direct financial impact, not just for health systems, but for Medicaid programs, employers, and insurers. But here's the catch. The system doesn't consistently invest in preventing those outcomes. It often spends more money dealing with complications after they occur. And that's a policy choice. Now, layer on top of that, the issue of equity. Recent data shows that overall US maternal mortality rate has improved slightly to about 17.9 deaths per 100,000 live births. But that average hides a much more troubling reality. For Black women, the rate is 44.8 per 100,000, more than 3 times higher than that for white women. And that gap doesn't close on its own. General improvements don't fix it automatically. So without targeted policies, localized investments, tailored support systems, and real accountability, those disparities will continue to persist. Sometimes even get worse while overall numbers improve, and that's continuity of care. One analysis of high-risk pregnancies found something striking. Women who had at least 10 prenatal visits had a significantly lower risk of death compared to those with fewer visits. The difference wasn't subtle. It shifted from roughly 1 in 3 to closer to 1 in 5 within that group. And that's not a minor operational detail. That's life and death. It reinforces a key point. Access alone isn't enough. Continuity matters. Relationships matter. Reliable ongoing care matters. So where do we actually act on this? A lot of real leverage sits with states and health plans. At the state level, policymakers can extend Medicaid postpartum coverage to a full year and make sure it actually works by supporting outreach, integrating mental health services, and funding community-based follow-up. They can reimburse providers like doulas and midwives at rates that make their work sustainable. They can simplify administrative procedures so providers spend less time on paperwork and more time with patients. They can invest in rural access where maternity deserts are growing by supporting birth centers, telehealth, and regional care models. They can require better data, tracking outcomes by race, ethnicity, and geography, and tie real consequences to whether those outcomes actually improve. And health plans have just as much influence. They can design benefits that make care easier to access, not harder. That means reducing friction, supporting care coordination, and integrating services like mental health and substance abuse treatment into maternity care. They can move away from fragmented fee-for-service models towards payment structures that reward better outcomes instead of more interventions. They can build networks that include community-based providers, not just large hospital systems, so people can receive care in places where they feel comfortable, safe, and supported. And importantly, they can listen to patients, not just through claims data, but through patient-reported experiences, understanding where care feels respectful, where it doesn't, and where bias or barriers still exist. Because respectful care is not a soft concept. It's a measurable and essential part of quality. Now, policy isn't just something that happens in legislatures. It's also shaped by institutions. Hospital leaders, health plan executives, and even employers all function as policy actors in their own way. Health systems can make participation in maternal safety initiatives a standard expectation, not an optional project. Hospitals can push for more care models that prioritize continuity and teamwork instead of siloed billing. And health plan leaders can embed maternal health expectations directly into contracts with providers, requiring data reporting, safety protocols, and equity improvement plans. And employers, especially large employers, have more, they have more influence than they probably realize. And they can demand transparency from the plans they offer. They can ensure that benefits include evidence-based supports, like doulas and extended postpartum care. And they can align workplace policies like paid leave and flexibility and what healthy pregnancies actually require. Because if somebody can't take time off for care without risking their job or income, then coverage alone isn't going to solve the problem. Which brings us to accountability. There are many well-intentioned efforts that fall short. It's not enough to say coverage exists. We have to ask whether people can actually use it. It's not enough to just list services. We have to ask whether those services are available, staffed, and accessible where people live. And it's not enough to measure outcomes. We have to ask whether anyone is responsible for improving them. So if maternal mortality rates remain dramatically higher for certain populations, and no one's incentives change, no bonuses shift, no contracts are affected, then that's not a data problem, that's an accountability problem. Real policy change means tying outcomes to consequences and incentives. It means boards reviewing maternal health data regularly, regulations embedding equity metrics in the contracts and accreditation, employers including maternal outcomes and vendor evaluations. It means creating transparency to ensure that these commitments are more than just words. And at this point, we don't need more reports telling us maternal deaths are unacceptable. That part's already clear. What we need are rules that make better outcomes the default. Because maternal health is one of the clearest examples of where smarter policy can deliver enormous returns, not just financially, but in human lives and long-term well-being and health. These tools already exist. The data is there. The question is whether we're willing to use them, or whether we'll continue to treat preventable harm as, well, just a part of how the system works. Now, in the next segment, we're going to move from policy into something just as important, how to actually implement these ideas in real systems with real constraints and real people. So again, thank you for listening. We'll see you in the next episode. This is Peter Boland, Better Health, Less Healthcare.